The ratio 0.63. Hazard ratio is what most people look at for Kaplan-Meier. It is literally the probability of a recurrence or some event relative to placebo or the control arm. So this is 0.63. There's 63% chance of recurrence compared to not taking drug. So if you did the 100 minus that, that's the percent benefit you got getting out of the drug itself. So any hazard ratio under 1 is great. Any hazard ratio over 1 means that your drug is more toxic than it should be. So this is 0.69. If you look at the division of the 3 different types, stage 3A was not statistically significant, but 3B and 3C both were. Let's take a look at Nivo, another anti-PD-1 treatment here. This is Nivo versus Ipi. Ipi was the standard treatment at the time due to a lot of the studies Lex Egermont did. So this is about 450 in each arm. Again, relapse-free survival, median survival, median follow-up, 60 months roughly. This is in 2023. And here are the final numbers. 5-year relapse-free survival, 50 versus 39%, with a hazard ratio of 0.72. So Nivo did better than Ipi. Overall survival, no difference between the two. So checkmate, this is a combination examination of adjuvant stage 3 and 4, combining both checkmate 238 and DEORTC 180-71. So if you look at the numbers, they really wanted to look at this mixed cure model, which basically say when you sort of look at that Kaplan-Meier curve, there's really 2 groups. One that were cured and another that was not cured. And the little trail off on the bottom suggests that the non-curers were sort of undergoing attrition at the time. So when looking at this, I just want to really show you the sort of hazard curves from here. Most of the events, and you see this in the Kaplan-Meier curves, there's a huge drop-off in the first 6 months to a year. Those are patients that innately are not going to respond. So that was the non-curable sort of group. So this is something to sort of think about as we start stratifying and start analyzing these patients. Are there sort of fundamental differences between these 2 groups? And if you look at it, stage 3 patients and those under 65 are most likely to benefit from adjuvant treatment. BRAF-MEK, which is probably used much less commonly these days for BRAF mutated tumors. This is a COM-BAD with a final evaluation at 2024. About 450 again, placebo versus the combination, median follow-up 8 years, relapse-free survival. And these are the relapse-free curves. 48% on drug, 32% on placebo, with that hazard ratio of 0.52. And if you look at overall survival or melanoma-specific survival, again, no difference, 8 years overall survival, no difference melanoma-specific survival overall. One of the reasons, probably not so much what they got up front, but often after you relapse, you start getting really effective drugs. So this speaks to what Chris and Christine and a lot of people talk about. What is the point of relapse-free benefit if overall you're still going to get benefit later on if you recur? You're just treating them sort of slightly up front. So with salvage therapy, they did pretty well. Let's look at the high-risk stage 2. These are the patients that walk into your clinic and they have this 3, 4, 5 millimeter thick tumor sitting somewhere. Currently, wide resection is still the #1 surgical sort of approach. Sentinel lymph node biopsy, if it's positive, you go down that stage 3 sort of algorithm. And what happens if you're sentinel lymph node negative? So here you have no disease. Do we give treatment to prevent the onset of disease? That would be, again, adjuvant treatment. Natil or pembrolizumab. It's also okay to give XRT potentially in certain areas, or there are probably trials ongoing right now. So let's look at pembro. This is Keynote 716. This is the 2024 follow-up, looking at the stage breakdown. Very few stage 2As, mostly 2B, 2C, and that's what the actual recommendations are going to talk about. All of them were sentinel lymph node negative, and those are the numbers, about 490 in each arm. Primary endpoint, relapse-free survival. And here you are with 36 months follow-up, relapse-free, 76% survival of pembro, 63% with placebo. If you did a ratio, that's 0.62. If you divided it, which is the difference in survival, that's about 12.8%. That's the delta. And here's 2B and 2C showing you the same data. They're all roughly with a hazard ratio of about 0.5, 0.6, but you can see the deltas kind of fluctuate between 12 and 13%. One thing to remember, you have a large enough trial and you go from 98% survival to 99, that's a hazard ratio benefit of 0.5, right? But a statistical difference of 1% in survival. So the delta comes into play when you have really early disease to sort of think about, especially in the setting that 18% of these patients undergoing these treatments are going to have some kind of severe immune reaction overall. This is distant metastasis-free survival, 0.59. It is significant that the delta here is 9.7%. And you look at who responded, males and individuals under 65 experienced the most benefit. It's not that women don't respond necessarily, it's that their survival in general is better. So the actual benefit boost up is not statistically as robust as men who have, obviously have a poorer survival. So that sort of brought it, gave them a greater boost overall. So let's talk about Nivo versus placebo here in 2023. Checkmate 76K. This is adjuvant setting. This is a 2-to-1 trial with 526 Nivo versus 264. Intention to treat at 12 months relapse-free. 89% Nivo, 79% placebo, so a delta of 9.6 and a hazard ratio of 0.42. If you look at the separation between 2B and 2C, pretty similar overall, both statistically significant at 0.3 and 0.5 hazard ratios, each with a delta that's around 10%, a little bit less, a little bit more. This is the intent to treat distant metastasis-free survival, and here, 93% with Nivo, 86% with placebo with a delta of about 5.6. So those are the numbers at high risk, all right? Clearly some benefit with relapse-free survival. Clearly the numbers look better with the hazard ratio, a little bit sort of more real life when you look at the delta overall. And something obviously to think about, you don't that much in stage 4 for the oncologist, is the real chance of a side effect with these drugs, which can be quite obviously severe and sometimes irreversible. Let's look at macroscopic disease. There you got a little lump, say, in the lymph node. Core needle, fine needle, core biopsy or fine needle biopsy is obviously one way to go to establish the diagnosis. I've had patients who have metastatic breast cancer thinking it was melanoma because they have a mass. So, making sure the tissue in the lymph node is completely discernible and diagnosed before proceeding is obviously very critical. Imaging, as I said, there's widespread METs. It's a slightly different algorithm overall because there you're treating unresectable disease at the time. Therapeutic lymph node dissection can be done, all right, which you sort of remove things, and then you can give adjuvant at that point. You've removed disease. There's no evidence of disease. You're going down that track. The other side is the neoadjuvant approach, all right? And here, you give the drug up front, hopefully shrinking that tumor a little bit, and then you take it out to see what remains in that lymph node. And this is where I think Michael talked about how much pathological disease there is, complete cure versus partial versus, again, no response. At that point, you can give adjuvant, XRT, or observation. So what I really want to touch on in the last section is the neoadjuvant. I find that this is being used quite actively, certainly at my institution. So let's take a look at the data. Pembrolizumab, this is in 2023. Neoadjuvant plus adjuvant alone. I think this is one of the ones that really, one of the studies that sort of put this on the map. There have been smaller studies overall, but this one was really profound. 2 arms you can see, 150 roughly in each arm. One you gave Pembro every 3 weeks, 3 times only. You took the nose out and you gave it 15 more weeks. The other one took the nose out and you gave it a total of 18 weeks. Same amount of Pembro, just broken up by giving 3 doses up front versus the rest after surgery. So that, in essence, is just the difference between neoadjuvant and adjuvant disease. And if you look at the relapse-free survival, huge differences here, 72 versus 49%. So if you gave it up front, clearly there was a much better relapse-free survival benefit compared to adjuvant treatment. If you looked at subgroups, almost all of them did better with neoadjuvant plus adjuvant compared to that alone. Nivo plus Ipi, this is in 2024, the Nadina trial came out, event-free survival. This is slightly complicated. You got this Ipi and Nivo for 2 doses, and then there was a question of path response, all right? Once you took the node out, there was a major path response, not much tumor left in the node at all. nothing happens. If there's a partial or no response, then you got some kind of adjuvant treatment afterwards. DNT if you have a BRAF mutation, or Nivo for 11 cycles. The other one, again, was the control arm with surgical removal and Nivo for 12 cycles. Pretty much the same graphs. Maybe they just colored it similarly, so it would remind you that these occurred, 84% versus 57% with a really significant hazard ratio. Didn't really make a difference between BRAF mutant and BRAF wild type overall. I think the critical point here is if you looked at it and stratified it based on pathological response, for those patients with a major pathological response, they didn't get any more treatment and their survival was 95%, all right? So just giving them a couple of doses, and if it completely shrank and you watched, these patients seem, at least in the interval, and that's a pretty short interval, so clearly longer-term follow-up is essential. It's really saying that you have that sort of high responsive tumor and that your survival is going to be really good. Nivo plus relatlimab, this is a trial that came out in 2025, single arm. You had the two agents. That's an anti-LAG3, by the way. Sorry. The relatlimab, then you got the tumor out, and you had, again, the combination for 10 more cycles. This came out in 2022, and this was their initial what's called the waterfall plot. And if you look at the partial response, 60% had complete response, so that's a pathological CR. And if you look now at the follow-up at 2025, this is stratified in terms of markers, all right? Low TIGIT, high B7. So those on the right-hand side, if you look at the major path response, they maintained pre-disease-free. Those with less than a major path response, obviously there were a lot more events. So again, they sort of the corollary of this trial is whenever you're giving them in a neoadjuvant setting and you watch the actual mass, if it shrinks and disappears, that's a really good positive sign. Dabrafenib, trametinib, again, has been looked at in 2024. This is NeoCombi, and again, it's a single arm trial looking at giving some DNT twice a day for 12 weeks up front, removing the tumor, and then following up with 40 weeks. So survival is not the outcome here. It really is looking at the percent path response. And little less, but if you had a good path response, 53%, that was probably a combination of complete and partial. And if you had no path response whatsoever, survival was quite low. The log rank didn't really meet significance. These are small numbers. But again, echoes the theme that in the neoadjuvant setting, if you can document a robust reaction up front, generally the patients do better. And here, neither relapse-free survival or overall survival were significant if you really looked at it. So take-home messages. Adjuvant treatments are now showing significant relapse-free survival for those with stage 2B and above. Again, the conversation to have between relapse-free and overall survival is active, it's dynamic, and it's argued upon all the time. Neoadjuvant approaches are here. Again, in our institution is used quite a bit. The effect of overall survival or melanoma-specific survival is still being explored. And the question really becomes, if you treat now versus later and leads to the same outcome, then maybe there's unnecessary risks for toxicity. Sort of the idea being, and this is a thought experiment, if you can cure all melanomas and you just waited and then they developed a relapse and you gave to them, they were all cured, it really wouldn't matter that you treated them up front. So it really comes down to the efficacy of that drug in the relapse setting. So biologically, if you think about it, if you gave it to them in a neoadjuvant setting and you somehow selected out resistors, then that's not a good that's not a good situation, because then you try to salvage them afterwards and they have less of a response. Or you can say, well, you gave them some drug and it tried to prime the immune system so they tend to respond better. So that kind of, post-relapse survival on the same sort of agents, that's the kind of analysis that's probably going to make or break the overall survival numbers in our approach to these things. So with that, I'll stop. Thank you very much. And again, thank you for staying so late in this meeting. Stay here.
Yeah. So let me invite the other speakers up. Someone left glasses up here. You? We all need our readers. So I know we have about 10 minutes left for questions, and I don't know if folks have a lot of questions. I know there's been a discussion about GEP in one of the other sessions just before this, or if we want Dr. Angeles to put up her 2 scenarios where she felt the Merlin test could be helpful. So a vote on questions versus new slides or whatever we can do. Chris is gonna, Dr. Bajakian is gonna stay after when I have to leave at 4 to field additional questions. But any questions offhand? And I'll have the panel come up. No questions, one question. And Christina, maybe I can put yours up, just because I think that's super interesting. I just wanted to be sure. Yeah, go ahead.
Survival versus long-term. I know the data is not in yet, but I think of President Carter, who they thought was in remission, but I think it was after 7 years, he had a recurrence. Do we have other data up to 7, 8 years on any of these studies to see what the effect is in terms of long-term survival?
You mean in the adjuvant setting? Like the overall survival in the adjuvant setting?
Yes.
Yeah, I think they're beginning to emerge. I don't know if in the latest ASCO anyone saw any of the longer-term follow-ups, but
Yeah, well, I mean, I'll let Christina also answer. We're still waiting on the overall survival benefit, and I don't remember his initial stage of disease. If he had stage 3, I know he progressed to stage 4 and was one of the first high-profile responders to anti-PD-1 therapy in his 90s with minimal side effects, and he did not succumb to melanoma as his cause of death, to my knowledge.
I think it was a brain met too, right? So that was
profound. But he had that sort of typical thing where we see disease recurrence despite our best efforts sometimes after even adjuvant therapy in the short term following diagnosis. But the long-term data on adjuvant therapy related overall survival is still pending. We know it improves relapse-free survival, and it's a big discussion our oncologists will have with patients. They may say, well, look, if the neoadjuvant data is looking so favorable, maybe I'll just wait until I recur, although that can have its downsides. As Dr. Angeles has said, it could be a much higher stage disease at that time, but they may wait till they recur, and if the therapy is going to do as well then, maybe you wait. So there's a lot of discussion in terms of timing immunotherapy, but upfront right now in stage 3 is kind of standard.
Can I just ask a related question, just with therapy? We've used in the past like a 5-year survival, but based on some of the information now available, are there patients who are doing fine at 5 years, but 7, 8, 9, 10 years relapse because of some cancer cell that did not respond to that therapy and now has grown and taken over?
I think if you look at the New England Journal, this is for stage 4, the chance of survival, if you made it to 3 years, is almost 96, 97%. All right, so there probably will be trail off. My bet is that because people start dying of other causes after 10 years, it's going to be really hard to follow that. But there's clearly ultra late relapses. I had a patient just last week who had a melanoma in 1979 that relapsed this year, but those are rare events. The one thing with the really widespread disease in the stage 4s, if you make it to 3 years, which basically says the 2-compartment model I sort of talked about, there's the curable and non-curable, right? That's the 2 compartments. After 3 to 4 years, you've sort of cleared out the non-curables, and at that point, what remains, it looks like, is probably the curable group that remains. So,
thank you, and you had some very nice presentations.
thank you.
I think the gentleman right there was,
Yeah.
right up here.
First question regarding the sentinel node biopsy. It's been dogma for as long as it's been available that ought to be done in the same setting as the wide local excision. I think last year in this in a similar forum, a respected expert refuted that and even said, you could do the sentinel node biopsy anytime later, which was really in context of a dermatologist office. We're not doing sentinel node biopsies, but we're tempted to do the wide excisions. But it's not been my practice, but I know I've practiced with people who do that. And, I want to know what your feelings are on that.
Do you want to start?
You can negate the ability to identify a sentinel node accurately via preoperative lymphoscintigraphy if you've done a wide excision, if you've oriented even a large excisional biopsy, horizontally crossing over afferent lymphatics on extremities. And that can be problematic. We can follow that patient with nodal ultrasound, which is still a very excellent way to follow these patients who are eligible for sentinel node biopsy and either don't undergo the procedure for medical reasons or the procedure isn't technically successful. But it's not optimal. Patients are unhappy. If they come to you and you say, well, we can try the sentinel node now, it might not work. And we typically would have done this at the time of the wider surgery. Now, there is one study looking at Mohs surgery, talking about the fact that if Mohs is done in patients who are sentinel node eligible, it can be done and not sort of disrupt that opportunity. But in that study, at least 85% of the patients underwent sentinel node biopsy first and then went to the Mohs surgeon to have those cleared. Okay, that's a different way to do it. It's asynchronous surgery. Is that valuable? We'll know down the line as we understand margin control and what the Mohs is offering. But I think ultimately, if for the patient's best interest, the procedure should be done in the same operative setting to maximize the accuracy of the procedure as a pathologic staging tool. And
Yeah, I have lots of patients that they won't map after wide excision, or when, especially on the trunk or the chest, we don't know if it's going to the right place. What if it goes to one site, but maybe it should have went to two, but the lymphatics over there are cut and scarred?
Well, it certainly validates my practice. The other thing is in this whole context of neoadjuvant immunotherapies and other therapies, but just neoadjuvant, if you don't have to take out the tumor burden in the lymph node, why do you have to take out the tumor burden in the skin? In other words, is the wide local excision even necessary?
It's being studied for stage 2. I mean, it's
Right,
being studied.
it's being studied. There is a lot of thoughts about that for the high-risk patients, that just giving immunotherapy up front and then seeing if you have a complete pathologic response, whether it's in the primary or the node, right? What we want to do is train the immune system, right, to make those T cells have memory so we don't have recurrence. So this is all being studied, but it's not standard of care yet. It's in clinical trials.
I look forward to next year.
Yeah, I just want to extend that thought for a second. I mean, the idea is that you have tumor-reactive lymphocytes on site being trained while you give them immunotherapy. So, treat while the thing's still on the skin, treat while the mass is in the lymph node. And people have asked them, why not treat when you have a sentinel lymph node, microscopic disease? Would that be helpful? Then the whole idea becomes maybe we should just treat first without doing a sentinel lymph node.
That's right.
And maybe that'll give a bigger result in the end.
Well, that was the scenario I presented initially, this patient with occult disease, but high-risk primary, stage 2C, but PET CT showed something, we could identify the nodes, do the FNA, and did neoadjuvant. I think it's interesting, we've had patients who come to us not infrequently billed as a stage 2C, big bulky tumor on the skin, who then have an obvious nodal met that we can feel. We find needle aspirate it in clinic, prove it, they see the surgeon and the oncologist bypassing, again, our side of things on the front end of disease. And those patients who get neoadjuvant invariably have shrinkage of the tumor on the skin. And when it comes out, it's not nearly as, we don't generally do a 2-centimeter margin. We're kind of saying, let's just get it out now with a centimeter margin. A lot of the time it's just necrotic tissue, no viable melanocytes. So does that have the same prognostic significance as the node, as we now know with the major pathologic response? But it's coming. It's going to be studied in injectables with an RP1 or RP2 agent in the skin for stage 2 disease. And so I think it's an exciting time. We may reduce surgery overall. Sorry.
Thank you.
Yeah, no, I think this is really exciting.
I'm going to step out, but please keep going. And I want to thank everyone. And Chris, do you mind taking over the panel moderation?
We're at time, are you sure?
If you guys are okay, just a couple more questions.
Yep.
Yeah, sure.
I just started using the GEP testing, but I'm only using it in kind of one place. I found the sentinel lymph nodes to be unreliable on the head and neck.
Yeah.
So I've only been using it in that population, tumor stage T1A with the base positive up to 3s, just because I find it unreliable. I've had a lot of recurrences even with negative sentinel nodes. So I don't know what your thought is on that, particularly head and neck. And I haven't seen anybody specifically looking at that population with the GEPs. So I just want to know your thoughts and your take on that approach.
Yeah, so when I first talked about sentinel lymph node and I gave that 98% sensitivity, that's in, all comers. But if you look at just head and neck, that goes down to about 85%. So there are a lot of head and neck sentinel lymph nodes that are missed for that, just because of the mapping, et cetera, et cetera. So that is one area that, we've been thinking about the results of the Merlin test, because in head and neck melanoma, they were actually better than when they looked retrospectively at some of the published data for head and neck, that they could pick out the low risk and high risk a little bit better. So that is something that I think could be very useful. I think whenever we think about using the GEP test, though, it's a discussion with the patient because there's still a risk, right? It's not like you can say